It's not, oh, there it is. Okay, this is the Healthcare Committee back again, after a short break. And we're going to continue with the introduction of patient advocates, to this committee. So first one is Lori Emerson. Welcome to the committee, Lori.
Thank you. And congratulations to everybody on being on the House Healthcare Committee. For the record, my name is Lori Emerson. I'm the Executive Director at the National Alliance on Mental Illness of Vermont. And I did submit a PDF file. I don't know, Kristen, you were able to share that with everybody?
Yes. Did you?
I did not. I didn't. Okay, all right. Sorry about that.
You have a hard copy of what you,
I do.
There is something
Yes.
on.
we have it all on
We
that.
have it on.
Okay, great. So you folks have it. All
Yeah.
right. So thank you so much for inviting us to be here today. NAMI Vermont is the independent Vermont chapter of the National Alliance on Mental Illness. And we're a statewide nonprofit grassroots organization that has volunteers that help administer all of our programs. So we have about 75 volunteers that help us throughout the state. And our core competency is our lived experience, whether we're family members or individuals with a mental health condition. And we serve the community, family members, peers, individuals affected by a mental health condition, as well as the professionals who serve them. And as our mission, we have three cornerstones with education, support, and advocacy. And we really live and breathe our values of empathy, acceptance, hope, resilience, honesty, self-care, empowerment, and inclusion. I mean, these are just so important for all of us, whether we're staff members, board members, or volunteers, that we live these values. We're organized throughout the state and have 5 different affiliates. And really what our affiliates are an organization of different volunteers that administer our programs in those different areas. And one of the things that I wanted to talk about with all of you is that we all have mental health, right? Just like we all have physical health. And how do we keep that balance with our mental health so that, you know, we're being productive, we're finding meaning and purpose in our lives. So practicing good self-care is so important for your mental health as well as your physical health, because they're both integrated. But then what happens when people don't take good care of themselves? You know, you can develop mental illness. And mental illness affects your brain. It's a medical condition, and it affects the way we feel, act, and think. And there are many different factors to be considered with mental illness. It could be biological, it could be environmental, or it could be psychological, could even be all three. So it is an accumulation of these factors that sometimes people develop mental illness. And everybody experiences it differently, so that one person with depression might be more severe than another person where they are not able to function. Other people with depression can function, and you would never know that they have depression. The good news is that it is treatable and there is hope. So that is one of the messages we always bring to people, is that people do get better and people can lead very productive lives. But a lot of people don't get help because of stigma. So they may feel shame, or they have bad experiences in the healthcare system where they don't want to go back because they've been traumatized. So just looking at the statistics with mental illness, 1 in 5 people are affected by mental illness. 1 in 20 with a serious mental illness like bipolar, major depression, schizophrenia. There are 104,000 adults that are affected. That's 1 in 5 people here in Vermont. And when you look at children, 1 in 6 youth are affected with mental health challenges. And especially in today's world, I think a lot more children are affected. So what does NAMI Vermont do? We offer support, education, and advocacy. All of our programs are free. All of our programs are done by trained volunteers. So we train everybody who administer our free programs. And we get our funding through grants and donations, as well as other support. So looking at the support piece of our mission, we have support groups, both for family members and individuals with mental illness. And we train people to be able to facilitate these meetings who have that particular lived experience, either as family members or someone with a mental health condition. And we have groups throughout the state. We have virtual groups as well as in-person groups. So we're always new people who want to give back and help others. And it's the same with our family support groups. We've been around for 40 years, and support groups have been a big piece of this. Other ways we support people are through calling our 800 number. We have a warm line. We hear from family members, individuals with mental illness, wanting to know about resources, wanting to know what their family can do. Because a lot of times when people are first affected by mental illness, they're in crisis and they don't know where to turn. And NAMI Vermont helps to refer people. We have a resource guidebook that's on our website that we share with families or even providers. It has a lot of the different resources available throughout the state, and as well as just some basic information about mental illness. And as well, we have presentations in the community. We have FaithNet, which is a program where we go into faith communities, and we want people to create a welcoming environment for others who may have mental illness. So helping to educate them about mental illness to eliminate stigma and be more supportive of other people. And we also have another program, which is called NAMI in Our Own Voice, where 2 individuals share their lived experience stories. And this helps to eliminate stigma with really realizing, well, this is my next door neighbor. This is somebody I didn't realize who struggles with mental illness. And we provide the training for people to go out and share their stories. And we've been able to help compensate people through this one program as presenters. We also found with the pandemic that youth need information. And so we're going into schools and having our program called NAMI Ending the Silence, so that we're talking about mental health, we're talking about suicide prevention, how to help a friend. And what we always do in every program we have is sharing our lived experience story. And so we try to find youth who will go into the schools and share what they've been doing. And that's where the youth really make the connection with people, is when they hear about the lived experience stories. We also have this cute little coloring book. We've heard from guidance counselors, nurses, we need to start sooner than middle and high school. So this is for elementary students. It really helps them to talk about their feelings, and it's a good activity book for the teachers. So we have lots of these if you know of anybody who needs them.
Lori, would you prefer to finish your presentation before questions, or would you be okay with?
Oh, I'm okay with, yeah.
I think Tucker has a
Yeah,
question.
In terms of the secondary schools, the high schools, how many of the schools have you been to with that presentation?
I wish I had all those numbers, but
Well,
last year we probably presented to about 4,000 or altogether 4,000 students. A lot of the schools keep having us come back every single year.
yeah,
So once we make that connection, they want us to keep coming back, like Burlington High School, Hartford High School and Middle School. We're up in the Northeast Kingdom, the southern part of the state. We were working with Alexina Federin, who was Miss Vermont a few years back, and she was going throughout the whole state. So we trained her in this program, and she was sharing her story.
because the reason I asked that question is I am sure with pandemic problems we had and the problems coming back to school that the kids are having, that the program that you just talked about would be really well received in any school.
Yes.
And I was wondering how many you're able to get to. When you say 4,000, that says to me, okay, if you include Burlington, you're talking about maybe 3 high schools.
Mm. Yeah.
And if you're going back to the same ones,
We might be presenting to a whole class, just a class or a whole grade. So it does depend. A lot of people have us come for a health class or, that way you're only reaching like 15, 20 people.
yeah,
But sometimes we can present to a whole school and, that's where we get our numbers up.
over Zoom, you mean?
In person. We prefer in person. Over Zoom, I think people check out and, the youth really like to hear those stories from people in person.
Sure, okay. Thank you.
Hmm. Any other questions so far? I know I've got a lot of information, so you can speed me along if I'm.
I think Brian actually has a question.
Yep. Are the coloring books free of charge and how can we get some?
They are free of charge. We can send them to you. We'll be here for Mental Health Advocacy Day, January 29th, and we'll bring boxes.
I know lots of kids who would appreciate them and just have some
Sure.
for other people, but, oh, thanks. I might even color one myself.
It is, yeah, at least you're saying that.
Yes, this is.
And you can download those too. So if you want to use particular pages.
That's great, like printing out worksheets.
Yeah,
Okay.
yeah.
Lori, before you go on, thank you for those coloring books. My kids have a few and they love them. Also, would you be able to get us some of the numbers about your presentations in school, both students you've presented to as well as staff?
Absolutely. I can send our impact report to you so you can see what those numbers look like.
Excellent.
We also provide education to family members with our family to family class. This is a class I took back when my sons were teenagers, and it really helped me to gain better coping skills for myself, better self-care, how to communicate, what to do in a crisis. So we've been having this virtually so that we can involve anybody in all rural parts of the state. We usually have like 65 people going through it in the spring and the fall. And we also have a one-day workshop. So family to family is 8 weeks long, but it is well worth it. So you get a lot of information about mental illness, how to help your loved one. But we also have a one-day program. And we also have a program for providers or professionals to be able to share our lived experience stories, what it means to be a family going through mental illness. So it gives them that lived experience perspective, not just the clinical perspective. And we also provide advocacy training. So we help people to empower people to share their lived experience stories. And I do a lot of the advocacy work for NAMI Vermont. So I'm sitting on statewide committees, local committees, work groups. We're providing opportunities for people to share their lived experience story, which really empowers them in their own recovery. And, we advocated really strongly for the 988 lifeline and suicide prevention number, as well as NAMI National was very active with getting this federal legislation through. And what we really look at are those three pillars: someone to talk to, someone to respond, and somewhere to go. And I am very excited to see that changes are happening now to be able to set up a better crisis system for people instead of going to the emergency room where you languish and you just sit there and you don't get treatment. So very pleased with the advocacy that all of us have done to get us to that point, and the state being involved in implementing that.
Lori, our last fall, I think it was late fall, the director of suicide prevention put out their final statewide plan regarding suicide prevention. Did you work and consult with the office on that?
I was a stakeholder that they shared the plan with, and I provided feedback where, looking at the family perspective. So they did make some changes based on my feedback for that.
Thank you for your work on that and advocacy.
And I'm on the Suicide Prevention Coalition, have been for the past 10 years. So we do a lot of work in that space.
Thank you.
Other advocacy work that we do, we create our own advocacy platform through our advocacy committee so that it helps guide the work that we do and what we support or maybe don't support. So with NAMI Vermont, everything is really led by our volunteers that help us do a lot of this work. And so I'm hoping you will I know Brian's going to be on the panel discussion for Advocacy Day, and Daisy has been helping me a lot with the planning for this. So it's going to be a big event. We're going to have a couple hundred people anyway. It'll be at the Vermont Supreme Courthouse Auditorium, and January 29th. It's a Wednesday. And would love to come back here and provide more testimony to the committee if you'd like to have us.
Daisy, do you have a question? Did you say if you're on the state standing committee or not?
I'm not, no. There are other NAMI members that are on the state standing committee, so we do share that information. And we try to get other members or volunteers involved in a lot of that work.
Speaking of volunteers, all these, outreach trainings and the work that you do, the presentations in schools and whatnot, those are all done by volunteers or staff?
They are.
And how many paid staff do you have?
We have 5 full-time staff.
And where does your funding come from?
Grants, donations, contributions.
NAMI walks?
NAMI walks, yes. Yeah, that's a big fundraising event. So you are all invited to our walk, which is coming up May 17th. And I'm happy to share any of these with you too.
I ask,
Oh, yes, I'm sorry. Yes,
So-
yes, Leslie.
how stable is your budget?
Being a nonprofit,
Yeah.
we get 50% of our income is from the Vermont Department of Health.
Uh-huh.
And then we raise another 50%. So we're always searching for grant funding,
And your budget is?
about 500,000. So we are very lean
Yeah.
in what we do because we have volunteers.
And I noticed, if I may, your state map, I'm from Wyndham County, so I'm it's in the southern part of the state.
Mhm.
Where is NAMI in Wyndham County? Where literally, is there a physical space?
There is not.
Okay.
Physical space, but there are volunteers throughout different communities and trained leaders so that they administer our programs. Like we have support groups, family-to-family classes. And we always want to have exhibit tables there and would even welcome all of you to help us with exhibit tables in your communities to get to know your constituents better.
So what you're saying is when I'm looking at this
Mhm.
and I see an 800 number. So if someone in my community was looking for services, they would call the 800 number and then someone would be in touch with them.
Yes, so usually someone's always there to answer the phone and, we just chat with people, find out what's going on and let them know about different resources. And our guidebook has a lot of that information as well to be able to help people. But sometimes it's just people just want someone to listen.
So does that mean it's usually just like a one interaction or is there ongoing? How does that work?
Yeah, it's just a one-on-one
Just
time,
once.
just that one time. Yeah.
Okay.
Yeah.
So you can count on a one connection, but then what would you do for someone who is struggling? What would?
So we would refer them to our support groups. If it's a family member, refer them to the family-to-family class. If it's somebody who needs support, it might be a designated agency that we refer them to based on where their community is, or if they prefer peer support, the organizations that could help with that.
Mhm.
So it's just listening and just understanding what people are going through and, recommending different options for them.
Thanks.
So kind of to add on to Leslie's question about services and who you help or work with. National Alliance for Mental Illness. Some of us, I wouldn't say I have a mental illness, but I struggle with depression and anxiety. Is NAMI, and I know that NAMI Vermont is aligned with the policies and much of what NAMI National does. Would you say NAMI Vermont is specifically for folks who identify as having a mental illness, like the more severe illnesses that you described, like bipolar, schizophrenia?
So we did change our mission statement to also include mental health challenges because a lot of people don't identify as having an illness. 1 in 20 have a serious mental illness. And we don't want to forget about those individuals who really struggle, who are not able to function. But it's about mental health. It's about mental wellness. And what we want to promote is wellness so that people can be resilient and bounce back and have better self-care. So we all have mental health. So we try to make the organization really applicable for everybody because anybody can get mental illness. It's a condition that, based on environment or psychological factors, maybe biological factors, that you could develop a mental illness. And we want to promote so you don't get to that point.
Thank you.
Thank you. Thank you for coming in. I appreciate all the work that you're doing in this space. Next, we have Ian Franklin, who is with the Vermont Association for Mental Health and Addiction Recovery. Which VAMHAR, which I think is a great acronym, by the way.
But much easier off the tongue for sure.
Yeah.
Just with respect to time, I want to kind of orient myself still in the 15 to 20 minute window, or are we a little crunched?
Maybe 10 to 15.
Okay. All right. So let me just start by saying I hope that out of today that you'll see me as a resource and that we can have ongoing conversations and I'll meet anyone anywhere. And I'm here in Montpelier and I hope that this will be the start of something and not the end all be all. So I'm 2 months ago, I became the executive director of VAMHAR. And I think that it's important for you to know kind of my background, but also VAMHAR's history as a way to get to where we are now. I'm a native of Guilford, which is down in the Brattleboro area. I am a resident of Craftsbury. I have a master's degree in history, a Master of Arts, and a Master of Science in organizational management and leadership. And since 2002, for about 23 years, I've been in health and human services, which is basically all of my adult life, working in the mental health and addiction arena. I've worked for for-profit entities and nonprofit entities. I was in downtown Burlington for 5 years in the addiction and mental health space. Then in 2018, I was appointed the director of the Recovery Center for the Lamoille Valley and moved over there. And then I was helped to create Jenna's Promise, and I was there for 2.5 years and created the Recovery Village model that we used to transform the community there. And then I became the director of VAMHAR and some other things as well. And I was the fourth ICNRC certified recovery coach in the state of Vermont. And among the more than 500 that VAMHAR has trained, 500 recovery coaches and 100 plus ICNRC certified recovery coaches. So I've been in my role for 2 months, and I have a lot of experience to share. I am also the great grandchild of a person who died of lithium poisoning as treatment for bipolar disorder. I am the grandson of probably 4 alcoholic grandparents. I am the son of a person who suffered a severe TBI as a result of getting kicked in the head by a horse, and who had a pretty severe psychotic break and spent 10 years so medicated that she was not present in our lives, but who in the midst of that healed to become my mother again. I am a person who has lost 2 cousins to opioid overdoses. One of my cousins is an EMT in town, saved one of my other cousins on Christmas Day the year before, and then found him dead a few months later. So I've not only lived it, on the front lines of the addiction epidemic and the mental health epidemic. I led our community through the effects of both the floods and the substance use crisis, and of the crisis of disconnection that resulted from the coronavirus pandemic, which was, in my opinion, one of the most catastrophic things that we could have experienced in terms of fraying the fabric of our communities. And yet it strengthened our resolve and our ability to respond to other crises by connecting community partners to care for people. So this brings me to, I'll come back to some of these themes, but VAMHAR was created as the Vermont Association for Mental Health in 1939 by the Montpelier Ladies Garden Club. It became a mental health advocacy organization. And truthfully, I don't know about 60 years of its history until the 1990s, when the entirety of the recovery of the non-12-step recovery community infrastructure really began to be built, starting with the Turning Point Center of the Upper Valley and Second Wind Foundation, and then spreading out from there to the now 12 recovery centers and many other recovery organizations. In 1997, we created Recovery Vermont, and it was named the Vermont Association for Mental Health and Addiction Recovery. And the pendulum swung way toward addiction recovery, and VAMHAR, by virtue of its size and its clout and its longevity over 85 years of history, became an incubator for many of the initiatives that we now have in our mental health and addiction system of care. It was the original parent organization and fiscal agent for Camp Daybreak, which is a camp for kids and families with mental health issues, the Me Too Orchestra, the Vermont Alliance for Recovery Residences, the Vermont Recovery Network, and others. We're the home of the Recovery Friendly Workplaces Initiative to this day. We have a $1 million HRSA It's actually $3.08 million over 4 years, but currently for this fiscal year, $1 million HRSA Northern Borders Regional Commission grant to work on rural workforce issues to train people, including some of the trainings that you see on your table here. We were, of course, we've had the Vermont Recovery Coaching Academy and the ICR and RC certification. We were the home of the Vermont Alcohol and Drug Information Clearinghouse for years. Unfortunately, as the result of some things that happened under one of my predecessors in February of last year, the Vermont Department of Health defunded us. And so we're kind of working through that, but still trying to really impact the system of care. So VAMHAR has long been an incubator and a supporter of other organizations. It never needed to advocate for itself. It never needed to fundraise for itself. Its funding was designed to support organizations across the system of care and statewide. And that's where I see us going is how do we strengthen the system of care and the intersectionality of these issues? We are not mental health and we are not addiction recovery. We're a mental health and addiction recovery. And I can't stress strongly enough, and I'll try to, be tactful but forceful, that mental health and addiction recovery could not be more interconnected. And I meant to say actually at the outset that, one of the lessons that I want to share with and impart with you and share with you and emphasize today is that you each have tremendous power to make a difference. I was going to say thank you, first of all, for having me here. And also thank you to Representative Black. Your work around gun waiting laws has saved lives. You may not know their names, but it has saved lives. If you need to look for a person who has created legislation and advocacy around an issue that has meaningfully changed lives, your chair is that person. Representative Tina on the front lines, Representative Burbico, I looked at your bios. You all have been working in the healthcare system. It's warts and all. We have a terribly dysfunctional, terribly costly, terribly disconnected system. You all have the power. You are at the table. You are the people who will make these critical decisions about what we spend money on and what we don't. But moreover, legislation can either save lives or cost lives. And there are things that are in the works to repeal laws, to do certain things that would be a major step back and would actually take lives and would cost us dramatically more money. And I think sometimes we look at spending $1 million and we think, holy cow, that's a lot of money in a state like Vermont. But $1 million is, in our healthcare system, about 6 cases of endocarditis, which is a disease from intravenous drug use, or treatment courses for hepatitis C. It is the things I have seen in my career, even in just the last 2 years. I have seen amputees from wounds from the xylazine epidemic that has hit Vermont. I have seen, which is incredibly costly to treat, and amputations and all these other things are incredibly costly in our healthcare system. We pay, $75,000 to $95,000 a person to incarcerate them. So when you see a PR machine that is talking about mass incarceration of people with mental health and addiction issues, I believe $1 million is a great savings compared to what you're about to face in the years to come. It is not that the carceral system will not exist, but there is a way to do that. And I think anyone at the leadership levels in the Department of Corrections would tell you that if we're going to do it, we need to do it right and we need to do it therapeutically. It is going to exist. We have a carceral system. People believe that public safety is inherently tied to law enforcement, but we pay in spades for an environment that does not heal people. All you need to know is that the long-term carceral wing in CRCF, where women are routinely, abused, is called the Bronx. when I go into CRCF, I see 137 genitators, women who experienced sexual and domestic violence and abuse and trafficking and other things, and then fell into substance use through in the midst of their depression and other things. 90% of women who are incarcerated in the state of Vermont, and frankly, I believe in the system at large, are survivors of sexual and domestic violence. I have spent my career working in domestic violence. My first 4 years were spent in what they call, and I don't like the term, but battered women's shelters in Massachusetts. I worked largely with Latina women who were going far away from their abusers and rebuilding their lives in another community. And I can tell you, and I've worked in hunger, and I've worked in poverty, and I've worked in a lot of different pieces of this system of care in mental health. They are all interconnected. They are all interconnected. And even within the substance use field alone, you have this situation in which prevention and recovery and treatment and interdiction, which is the carceral system, are pitted against one another for resources. But in reality, they are all parts of the same system of care, and they are integrally connected to the mental health system, even though the funding streams from VDH and DMH are largely sequestered, our systems of care are largely sequestered. But anyone who is working in the mental health and addiction field would tell you that people working on SUD are also addressing mental health issues. I realize I'm making a generalized statement, but and anyone working in mental health is also dealing with other issues that could include these other types of trauma and substance use and other things. Yeah,
I think Daisy had a.
please, yes.
I think you just made the point that I was going to really lift up and appreciate is that what you're talking about is really the human experience that often we don't get the opportunity to bring to light as acutely as you have, and how it touches on all the systems. And we don't often hear about the co-occurrence of an addiction and a mental health challenge that folks experience because we don't hold the addiction portfolio. But your organization actually merges those two things the way that they merge in the human body. And I'm so glad that you're here and that you're bringing in the real experience of how that often intersects with the criminal justice system. And you're right, the system does need to work together more. And sometimes we are, and just simply because the way that we work in the building and in the system, we don't get the opportunity to hear about it and talk about it in this room. And you've given us the opportunity today to talk about that from a human perspective. And that's why I'm so grateful that you joined us and that you're here in the role you are now. And hopefully we'll be hearing from you more, but I'm just really grateful for the work that you're doing.
Thank you.
Leslie.
You said something really important to me, and it was about prevention.
Yeah.
And you talked about endocarditis. How do we measure prevention? And I'm not asking you to answer that question. I'm asking us to answer that question. And I'm asking who's ever listening for us to, and I don't know how to figure that out because I think we spend a lot of time downstream and not enough time upstream in working towards prevention. But when we can't measure it, we don't know that we can have the impact of our work. I think that's really important, and I really appreciate you bringing that up.
Yeah, and I actually would love to have a further conversation about this, but let me just make this actually ties deeply into what I'll use to wrap this up and what I think, I could frame the problem, but I'd rather frame the solution. In the last couple of years, and I'm sure you all heard it, we, like the state of Vermont, put a ton of money and we all put a ton of time into meetings about the Iceland model, right? Do you remember that? Okay.
I didn't.
Okay, so the Iceland model, which is ironic. So there's the Iceland model, and they're basically saying like these Scandinavian societies, they have a different way of doing things. So even the CRCF, the vision for building CRCF is to have the Scandinavian model of incarceration in Vermont, which is this much more holistic model. So the Scandinavian or the Iceland model that was created and then transported to South America, and we brought in all these consultants, the state of Vermont did, And we spent so much time looking at it. And in the end, they completely missed the point of what the people were telling us about the Iceland model, which is not that we need to go into the schools and tell kids not to do drugs. It was that we need to build stronger communities. My goodness, like that. Like, yes, it takes money, but it's about how we interact with one another. It's about how we support our kids. It's about the activities and giving them outlets that are not using drugs to hide the pain and the diseases of despair and the isolation. It's to bring people together. So it was investing in sports teams and in after school programs and community centers and targeting and really helping the youth who are the most vulnerable. And so basically the state of Vermont kind of threw up its hands and said, we don't want to spend money to build all these programs. That's too hard. That's too costly. And it was really all about community. So I will try to just wrap up my thoughts. And I have so much that I want to share with you. And it's a little unorthodox, I realize, to not have a PowerPoint and stuff. So Vivek Murthy, the Surgeon General, just released a report, and I'd just like to read a few words from it, and it's called My Parting Prescription for America. I encourage you to read it. You would expect the Surgeon General to take a medicalized approach to this, right? So he says, over time, I came to appreciate that my parents weren't teaching me how to build community. They were giving me the formula for fulfillment and well-being. Why? Because community is a powerful source of life satisfaction and life expectancy. It's where we know each other, help each other, and find purpose in contributing to each other's lives. The core pillars of community, relationships, service, and purpose are powerful drivers of fulfillment. They can significantly influence health outcomes, including premature mortality, heart disease, depression, and anxiety. Community also gives us the strength and resilience when facing the big challenges and countless paper cuts that come with moving in the world. I'm going to share a couple of other things. I truly, basically, Jenna's Promise, our recovery village model in Johnson and the Lamoille Valley, was the manifestation of our belief that building a stronger community will prevent crime, will prevent substance use, will rebuild families. And we built community centers, and we bought buildings, and we revitalized them, and we provided businesses, and we provided jobs, and we did all of these things to rebuild people's lives and their families and the sense of community. If you want to talk, look at this theme again, there's a book called Chasing the Scream and Lost Connections by Johan Hari, or Dreamland by Sam Quinones. And they all talk about the need for community. Sam Quinones says, in a time when drug traffickers act like corporations and corporations act like traffickers, our best defense, possibly our only defense, lies in bolstering community. Johan Hari, who has become kind of the patron saint of the Vermont recovery community, the phrase that we often say is, the opposite of addiction isn't sobriety, it's connection. Sobriety is a moment in time, a connection and healing and togetherness, and all of that is a lifetime. The actual paragraph is, the opposite of addiction isn't sobriety, it's connection. It's all I can offer. It's all that will help you in the end. If you're alone, you cannot escape addiction. If you are loved, you have a chance. For 100 years, we've been singing war songs about addicts. All along, we should have been singing love songs to them. What's my point? Our system, as it is right now, is built to marginalize, ostracize, exclude, imprison, and basically kill people who are not being given the chance to survive and to heal. And I will tell you from my 23 years and my personal experience in life, people can heal, that nobody is beyond redemption, that if we give them the support, if we give them the sense of belonging and purpose in our communities, they will become great citizens, great employees. They will meaningfully contribute to our lives. I'm going to read you one last thing. Do you know Gabor Mate? So he is probably one of the world's foremost, if not the world's foremost experts on trauma. He said, if I had to design a system that was intended to keep people addicted, I'd design exactly the system that we have right now. I'd attack people and ostracize them. And Johann's writing about this in his book. He's seen that the more you stress people, the more they're going to use. The more you de-stress people, the less they're going to use. So to create a system where you ostracize and marginalize and criminalize people and force them to live in poverty with disease, you're basically guaranteeing that they will stay at it. Our system has become about who it will not serve. It will not serve sex offenders, arsonists, people with bipolar disorder, schizophrenia. Now everybody's calling it borderline personality, which is a euphemism for a whole bunch of different a range of experiences. I'm telling you that there are organizations in the state who blackball people based on the conditions they have because they're too hard and too expensive to treat. And those are the very people that people fear. That press release that went out last night about an omnibus bill about public safety, fine. That's like, do we need public safety? Do we need safety? Do we need a sense of safety? Absolutely. But I'm telling you that as long as we aren't actually helping the people who we are afraid of, it will never end. It will never end. And we will spend so much more money than we would if we actually did it right. So thank you.
Thank you.
Thank you very much.
If it's quick, I think we'll just really
It's a
quick.
quick question and then just like a validation maybe, or something. Maybe also the validation will be, if you come out on the street with me and talk to the people who are homeless right now in Burlington, they'll say exactly what you just said. They feel like people want them to kill themselves. They want them, and that this is like genocide. And what press release are you talking about?
The one about the omnibus safety.
I missed
Public
this.
safety. From the governor's office.
I saw
That was the executive order.
I saw the agency
Order.
of public safety thing though, and I was horrified by that, so.
And like things need to change,
Yeah.
but this is not taking into account those of us who are living on the front lines of this and who are actually working with the people and who have actually seen people who have been blackballed, who are not, who everybody says don't want help. It's not true. It is not true. And if you read The Least of Us, which was Sam Quinones's book, or Dreamland, he talks about the rise of P2P meth and cocaine psychosis. The drugs are causing mental health conditions that cause people to do things that, yes, they are terrible, they're abhorrent, but believe you me, shame and guilt, we don't have to shame and guilt people. They feel it. We feel it. Like they feel it on their own, and it sends them into the black hole of addiction and mental illness that they see no hope in. So I'll just thank you for your time, and
Thank you, Daniel,
Appreciate it.
Thank you for your passion and your advocacy and all the work that you're doing. Thank you so much.
Amazing amount of
Thanks
stuff.
for coming in.
Like, so I was really having a hard time. I don't know if you would be willing to like do a summary and send it to us.
Yeah,
That
for
would be
sure.
really helpful.
You have a recording too.
Yeah, it's true, but I'm not listening to it again. Sorry.
No,
Thank you, Dina.
thank you again for coming.
you.
Okay, listen at double speed, I do that.
I have a hard time.
My ears are
I
open.
just want to make sure that we leave enough time for our guiding principles, because as
Oh.
Daniel was talking, I wish I could go like this, which
Yeah.
is what I wanted to do, but I was.
You need a mirror.
Yeah, I need a mirror. Then it would be backwards and I wouldn't be able to read it. So next we have Michael Rollo from the American Cancer Society.
Chair, I will not take the full whatever 10 or 15 minutes. I will be brief. So you're next to Tina, who's going to come after me in your other work. But I'm Mike Rollo. I'm the Government Relations Director for the American Cancer Society Cancer Action Network, which is a mouthful, so we say ACS CAN. And I have a handout here for it. I believe you already have it, but I'm kind of a Luddite, so I like paper.
I'm with you on that.
I was a history major, and if it wasn't on paper, it didn't happen. Anyways, so thank you very much for having me this morning. ACS CAN is the advocacy arm, if you will, of the American Cancer Society. We support evidence-based policies to help alleviate cancer as a major health issue. But I'm also going to talk to you a little bit about what the American Cancer Society does in Vermont as well. I think we'll start this way. in 2024, I don't have the data yet for 2025, the estimate rather, but 4,500 Vermonters would be diagnosed with cancer in 2024. And unfortunately, approximately 1,460 folks will lose their battle to cancer. So with that in mind, kind of sobering thought, I know, but I want to discuss why we do the work we do. From the ACS CAN, the advocacy side of the house, there are two buckets, if you will, of work that we focus on, and we're going to be focusing on in 2025. That's ensuring access to quality care. Access to care is sort of the bread and butter of the work that I do. And then it's cancer prevention and early detection work. So what do we mean by access to quality care? In 2025, we're going to be working on improving coverage to biomarker testing. I believe that bill, once it's finally makes its way through Ledge Council, a little bit of a backlog, as you know, will be coming to this committee. And we look forward to having a robust conversation with you all about what biomarker testing is in general and why it's important to folks dealing with a cancer diagnosis and treatment and survivorship, for that matter. It's important to all three phases of the cancer journey. We are committed to working on, it may not be happening this year, I understand, but we are committed to working on paid family medical leave, as we believe that it's important for cancer patient survivors and caregivers to have access to time off without the thought of losing their job or their income. We're not quite sure what it will look like, but we're committed to helping with the process. And then cancer prevention and detection. We are committed for funding to the breast cancer and cervical cancer screening program, reducing the toll of tobacco in the state. Actually, before I get off breast and cervical cancer, I'm sure will all recall 2 years ago now, I believe, a report that came out showing that breast cancer screening was on the decline in the state of Vermont. And that's something we do not want to see, because I think the next logical, we follow that. If the screening rates are going down, you're going to start seeing incident rates going up, and you're going to find people getting, when they do finally go into the doctor and gets diagnosed, you're going to see incident rates going up. We don't want to get to that at a later stage. I'm happy to answer questions.
I know Mari has a question, but I actually have a question. Has there been any data on access?
On access to the
access for breast
to the screenings, or in general to treatment? I just want to make sure I understand.
Screenings.
Screening. It was the last time I saw they were still working on that. I may have missed a report, so I brought my pad just in case you had questions, so I can find out for you. I will try to find out. I don't know the answer. I'm sorry.
Okay. And Mari?
Is the reduction in numbers of screening by any chance related to a change in evidence-based professional recommendations about the frequency of screening?
I don't believe so, only because we've changed our screening guidelines not too long ago, and lowering the age. So I'm not sure that that's the reason, but I'll ask the researchers there.
If you could, I do believe the frequency has possibly changed, and the ages based on history, family history. So that would be helpful.
I mean, it could have. I mean, I don't want to get too far into the weeds, but I know we're seeing in a number of cancers, we're seeing folks present at earlier ages, that we haven't seen before. So, and there's ongoing research into why. It could be a whole host. It could be, in fact, Good Morning America this morning. I saw a report. Our chief medical officer, I had no idea this was happening, was on Good Morning America as I was waiting to come up here, walk up here. And they were saying, it could have to do with genetics. It could have to do with tobacco use, or preventable versus non-preventable, which would be like genetics. So there's a whole host of reasons that are coming out, but it's kind of timely that this report just came out, I guess it was released this morning, that's why it's out on GMA. So, but I don't have it yet, but I will be happy to put that on to you. Let me just make sure I make this note so I don't forget to get you the information. Okay. Tobacco prevention and cessation. Tobacco use or not using tobacco is the #1 preventable way of not developing a cancer. It still is after all these years. So we work on trying to come up with policies that will help people, whether that's funding for the tobacco control program, which is next door. I understand that, but I just want you all to be aware of that as we work on. And then funding for, in all 50 states, funding, protecting the funding, less more an issue here, but it makes the list of protecting funding for the cancer registry program. With that, I think I'm going to stop on the ACS. Oh, no, if you had a question, I'm sorry. On the ACS CAN side.
That's not my question.
Okay. So I was going to talk to you about what the American Cancer Society in general does in the state. We are a trusted resource for folks that may have gotten a diagnosis or have a loved one or a caregiver. And I would urge you all, if you need information, to go to cancer.org. And we also have an 800 number that we're very proud of. We have a call center that is staffed 24 hours a day, 365 days a year, where you can call and talk to somebody, a live person. Whether that you've just gotten a diagnosis and you're scared and you heard everything, or you thought you heard everything your doctor said, but I kind of like to think of it as Charlie Brown's teacher talking to you once you've heard those words. You know, people don't always process, what they're hearing. It's a very scary process. So it could just be you want to talk to someone. It doesn't have to be that they're going to give you information. You just might need help to process. But the resources there, and we have folks that specialize in certain parts of the country, so they will know that there are. You give them your zip code, and you say you live in whatever town you say you live in the state. They can tell you what programs are available locally, whether it's through the Cancer Society or other nonprofit or governmental agencies. So it's a wonderful resource, and that number is 1-800-227-2345. But if you go to cancer.org, you will see all of that. I'll also be remiss if I didn't mention that the American Cancer Society is the largest non-governmental funder of cancer research in the country. The only people that raise more money for cancer research or provide more funding for cancer research is the federal government. We're very proud of that, and we do that through fundraising. We don't accept federal funding. We don't have any state funding. It's through large grants, like the Kaiser Family Foundation, those sort of things, and through our walks. I know it mentioned NAMI has a walk. We have a few as well. We have our Making Strides Against Breast Cancer walks and our Relay for Lives. One happens in the fall, one happens in spring, early summer. And if you go to cancer.org, you find all the information about the local walks. But we also provide services to your constituents. We're very proud of our Hope Lodge in Burlington, on the campus of UVM Medical. It is a place where if you're going through cancer treatment and you need to be in Burlington in this case for an extended period of time, and it's very expensive, as you all know, to rent a hotel room. It's for you and a caregiver. You can stay there for free of charge for as long as you're going through treatment. And we're very proud of that.
A great place.
Thank you. There's only 2 in New England, one in Boston, and you can imagine they're very busy in the city of Boston, but we have one in Burlington too. We should be very proud of that. And that was founded by some volunteers that did the fundraising for it, and we should all be, we're listening to the previous speaker talking about community. Well, it's that in cancer care too. It's very important. And excuse me, I'm just going to talk quickly about some of the other programs we have. We have a Road to Recovery program where we have volunteer drivers. You might not need to stay at Hope Lodge, but you still can't drive yourself to your doctor's appointment. We have volunteer drivers that will pick you up and drive you. And a number of legislators, some serving and some that are no longer serving here, have been volunteers with that program. We're very thankful for that. We also have support groups that we run Hair loss and post-surgical products are provided to patients. There's a whole host. And if you go onto cancer.org, you can see that. But we're very proud of what we're doing for the residents of the state. And I'm just going to leave you with one last thing. We have our annual Cancer Action Day where we bring volunteers to the state. You may know, State House, you may know it as our ice cream social. It's very popular. It's going to be on March 18th this year. So you can get it on your calendar. I believe it's going to be in the afternoon, but I'll get you all the details as we get closer to that date. But we'd love to have you all there. You can meet some of our volunteers, some of which are in active treatment. Some of them are caregivers. Some of them are providers. You can get to hear from their experiences. And I think it's always and you get some ice cream on top of it, but it's always a worthwhile time to hear from those folks. So, last thing I want to say, and I should have started with this, was thank you. This committee has been very supportive of our past work. Just in the last year, actually, you passed follow-up mammograms for diagnostics and eliminating the cost sharing for that. That was very important, Representative McCann's bill. And thank you for that. And with that, I think I will stop, because I know you're far behind and wants to go too. So,
Thank you, Michael, thank you so much.
Thank you.
I think we're going to move on to Tina, quick, just because we're running out of time.
you can,
Want to say it?
of course, yeah, I will leave you my.
For him. I want
Oh.
something on the record, but you don't have to do it.
Of course,
Fine.
thank you.
Hi, Tina. Tina's with us today. Thanks for being with us.
Oh, of course. Thanks for having me. And I will keep it brief because you never want to be the last person between lawmakers and lunch, right? And so I'll keep it short and sweet. I will say that our mission not that our mission has changed over the years, but our mission statement has, and it is now to be a relentless force for a world of longer, healthier lives, which I can imagine would be yours as well. And so we hope to work with you this year and ongoing on a lot of efforts. I like what Representative Goldman said earlier about, finding ways to measure prevention, because I feel like there really isn't a focus on that. And it can be so significant, right? It can be a cost saver. But I feel like when analyses are done on impacts, right, that isn't always factored in. But I want to start by saying thank you to this committee for your support. Last year, we had a request for a small appropriation to provide hands-only CPR kits for schools across Vermont. The committee did mark it as one of their priorities, and we did get the funding in. That process is underway to get those kits out to schools. And I want to encourage this committee to walk the walk with that issue and become part of what we are calling our nation of lifesavers, people who are prepared to act in a cardiac emergency. If you want to write down this date, I will, of course, flood you with emails, I'm sure, too, about this. But next Friday, we'll be in the card room, and we'll have our little mini mannequins with us, and you can take a minute or two to learn hands-only CPR. Even if you know it, just try it again so you get that good muscle memory. It's easy, no rescue breaths. Literally, you can do it in a walk to the cafeteria from your committee room. And we'd like to make it a little fun this year to have the House versus the Senate to see who can train more people to really have a nice, healthy competition with it. So that's next Friday, if you want to stop by. Our biggest probably legislative priority this year may come before your committee. I'm not sure. I know it'll go to the education committees, and I don't know if it'll make a trip to the health committees, but wanted you to be aware of it. We are working on legislation that would require cardiac emergency response plans in schools and sports, and it would just ensure that schools are prepared should a cardiac emergency happen. And you may say, well, do they really ever happen in schools? One just did. Less than 2 weeks ago at the basketball game at Spalding, and Milton sophomore had a cardiac arrest 4 minutes into the game with an undiagnosed heart condition. And exactly what happened is what we want to have happen. They were ready to act. The athletic trainer had an AED that they got and put on the student. 2 coaches performed CPR, and he was revived before rescue even came. That's not likely to be the case in all schools across Vermont, especially in rural areas where EMS may take a while to come. If schools aren't prepared, then, this can be a real lifesaver. The reason it's important for you all to know about this and be supportive is the survival rate currently for cardiac arrest outside of a hospital is 10%. That means 90% of the people die. And that's an awful statistic to have. if we have these plans in schools where we've seen these in schools, they can more than double survival rates. And so we'd love for your support when this comes around. Related to that effort, on February 7th, we'll have our legislative breakfast in the cafeteria, and you'll be able to meet a whole bunch of people that have anything to do with this. We have athletic trainers, school nurses, PE teachers who are all big advocates of this issue, and survivors as well. So we would love to have your support, but certainly start it next Friday with getting some hands-on CPR training. In terms of some legislation that might come before your committee, last year, your committee worked on Medicaid expansion efforts with H721, I think was the bill number, but really with the goal of getting more people in Medicaid so they'd be covered. Our particular interest, if you do something like that this year, would be to increase income eligibility limits for pregnant postpartum women. Currently, I believe it's 213% of federal poverty level. We'd love for that to get over 250 if the committee was so inclined. And there's great reasons for it. You can imagine it improves the health outcomes for both moms and babies when they have early care. And it decreases both infant and maternal mortality rates. And maternal mortality rates have more than doubled since 1999. So there's really a good reason to act. Those are two that are kind of might come before you. As you probably know, we will always be an advocate for tobacco prevention because, as Mike said, it is the leading cause of death, preventable death for both heart disease and cancer. A number of the risk factors for cancer are the same for heart disease. So tobacco will be an effort that we always will fight, would love your support on, including funding for the tobacco program. I know that's an appropriation issue, but the more we can do to educate about the dangers of these products, the more we could prevent youth from getting involved with them. This year, we'll be working on, doesn't sound very sexy, but a tobacco retail licensure program just to make sure our laws are strong concerning preventing kids from taking up the habit. And that would include funding for a position to do some online enforcement to make sure these products aren't being sold online, which there's currently supposed to be prohibited in the state of Vermont. We, like the Cancer Society, and it won't happen this year, but we'll be pushing consistently for a paid leave program in Vermont to make sure all Vermonters have access to paid time off, especially caregiving when you have somebody who might be having cardiac surgery and they need to have the necessary time to recover. Also, we know that makes sure that babies and moms get good starts too. So it's really a great program once we get around to be able to fund that and get that going in Vermont. Early childcare, again, is an issue that we support because it gives kids and families a great start. And that has lasting effects when you probably are all aware of that, but when you have good quality childcare, it can keep kids out of prison later in life, get better jobs. There's just such a great link to better outcomes in the future when you have great early childhood education. And just lastly, I will always, and Representative Goldman, I think we've talked to you and you're supportive of this, we'll always work for sugary beverage tax and excise tax in Vermont because of all the good that it could do as we consider funding options to solve the education funding crisis in Vermont. If that is floated as a balloon along the way as a possible source for funding, I would encourage you to support it because if we had a 2-cent excise tax on sugary beverages, it raises over $30 million in Vermont. So the revenue alone could be used for really good things. But also when we increase the price of unhealthy products, we steer people to healthy products. And so it has a significant impact on obesity. So that's it for me. I'm happy to answer any questions. I know you're limited for time, but I look forward to working with you.
I actually have a real quick question, just because I was thinking about it as you were listing through the things that you advocate for. If it's been a number of years, and don't ask me to count the years, the You First program was extended to cover cardiovascular screening tests. Is that still in place? If so, do you know what the utilization on that?
I don't, and it was, I can't remember what was the last iteration because it was part of the Wise Woman program too through VDH. And I think for low income women that they did screenings in Vermont. It's something I can look for look into and get you the information on. That is related to one of the things I was remiss in talking to you about. I just don't know in what shape this would happen, but hypertension is a huge issue in Vermont. We call high blood pressure the silent killer. Many people who have it don't know that they have it until they have something like a heart attack or a stroke. There were 4 stakeholder meetings that were held across Vermont from I think it was July until November, by everybody, the hospitals, One Care, Heart Association, all kinds of physicians' office to look at this, because we're not really moving the needle there. And we haven't come up with an answer as to what more to do. It may be funding, it may be a pilot program, that kind of thing. But I would ask the committee to, when something like that comes forward, to be supportive of it, because it is something that really causes a lot of cardiovascular problems. And the program that you mentioned, Representative Black, does screening to find things like that. So I will put it on my to-do list to find out where that is in Vermont. I'm just not sure the utilization or what the current status is, but we'll find out.
And I think we have time for one quick question. I'm gonna go with Leslie, and unless it's pressing, Mari, are you?
It's quick. It was just,
Okay, well, let's go to Leslie quickly and then Mari.
I just wanted to thank you, Tina, for acknowledging the notion of prevention, and I didn't hear you say a whole lot. I'm talking to Dan or Daniel, if that's okay, about prevention or research about preventing cancer. So a lot of what you talked about end of, treatment, people already diagnosed, getting early diagnosis, that's all important and good. But what about upstream? Once again, I'm stuck on this, Tina, how do we prevent diabetes? We're not doing it. We're treating people after the fact all over the place. And it's very frustrating. So I'm just saying that this is 2 more examples in different arenas of our health. We had a mental health example. Now we have a cancer example. Now we have a cardiovascular example of we are doing tons of treatment and not a lot of work on prevention. I am throwing out there.
No, I agree with you. And I think part of the problem is that prevention takes time. And unfortunately, sometimes lawmakers have a 2-year term. And so you don't necessarily see the results in the second year, so they can go home and say, we made this progress. It is progress that happens over time. And some of the things that are impactful aren't always popular, right? So eliminating sales of tobacco products, having a tax on sugary beverages, retailers push back, right? So that's some of the way they make some income. And so it is a struggle sometimes, but those are some of the effective ways to make preventative efforts.
Yeah, thank you.
And Mari?
I just want to thank you for your efforts to promote high quality field CPR and encourage everybody in the room and to be skilled yourselves and have your friends and family be skilled. I take care of the patients on my floor after they've had their heart stop or cardiac arrest. And we have a phrase called time is tissue. When your heart stops, your heart is not getting blood and oxygen. And if someone in the field can perform high quality compression, meaning they're deep enough and they're at the right rate, that gives the person a much higher chance of living with less sequela or less problems caused by that cardiac arrest. So please do stop by Tina's table and learn CPR with high quality compressions.
And that, as I mentioned, is hands-only CPR, which is great. And I want to see all of you there. It'd be wonderful. Plus, we're going to make it fun with some other stuff too, and some fun little giveaway stuff. But we are also working with the Capitol Police and Sergeant of Arms office too. The Capitol Police, I had a chance to talk with them recently. They're very proactive about wanting to get staff and legislators trained in CPR. So they will offer the full certification CPR, where it's more like 4 hours and you learn the rescue breath too. Coming up, and we'll be working with them on funding some of that, because we would love to have a lot of people trained, but hands only for CPR is the first step, and there's no reason not to do it. You probably have 2 minutes in your day, and we'll be there to say hi.
Let's be the first committee to get to 100%.
Thank you so much, Tina, for joining us today. I appreciate it.
Thank you.
So I'm going to turn it over to Tupper here in a second. So we're going to move on to our guiding principles. I just want to say that yesterday we heard from a long list of provider advocates. And I envisioned that today we would hear from a long list of advocates on behalf of Vermonters and people. And I struggled, even the late time that we have, I struggled to fill the time in. And I was thinking, who advocates and who's here representing the people? And then I remembered, that's what we do. We represent Vermonters and we represent people. And that's why I wanted to deal with our guiding principles today, because these are the things that we have agreed to that allow us to serve the people that we have been elected to serve and to represent, because we're the ones that represent the people. So with that, I'm going to turn it over to the representative from Barrytown, Upper McFun. Francis.
Nice introduction. I have, and correct me if I'm wrong, I have one suggestion for, in addition to this. Is anybody here? Did you have suggestions that you sent somewhere? I didn't get it. Okay, good. So that's what we're going on. So that says we did a good job in the first place on this. Let's talk about and how important is this to us? You just heard, we're representing the people. It's very important as we go through developing legislation, passing legislation out of this committee to another committee or on the floor, to make sure that we are representing the interests of those people that sent us here in terms of healthcare. Now, the one thing that has been added, it's a recommendation.
It doesn't need to be added.
What?
It doesn't need to be added.
No,
It's
no,
up for
that's
discussion.
why I changed my tone. The one recommendation that we have is to make someone's life better today.
So making, it would be making. If we stay consistent with our.
Now, I'm gonna have the person who suggested this, because she had so much to say about these things last time around.
I did.
And I think she was a little ticked off because she didn't get everything that she wanted.
It's a good thing that everybody's good with them because we sure spent enough time on
Yeah,
them.
that's right, that's right. Okay, so that's it. Making someone's life better. And I don't know if you want just today or just end it with better.
Well, so much maligned, but also much referred to. I thought about every single bill that we did last year, and I could look up and I could see something in our guiding principles that I thought we could do that. But I will tell you that my own personal guiding principle, and it doesn't have to be everybody else's guiding principle, is one of the things that you learn about, particularly in this committee, is that we're often in a position of feeling like we need to fix everything. And one of the things you find out is that it's really hard to fix everything, even with your best intentions. I think, Mike Fisher spoke about that today. And, we have federal guidelines that really mandate most of what I think a lot of people's frustrations within our healthcare system is. And we have this healthcare system that sometimes it always feels like we're nibbling around the edges, and that some of the things that we could do just sort of nibble around the edges. And I have a personal guiding principle is I cannot make everyone's life better, but maybe today I can make someone's life better. And that's what I try to be. My guide is just try to make someone's life better. Does every single piece of legislation that we have, does it does it help someone without harming someone else? And that's my guiding principle. So I'm throwing it out there and
Melissa, is it
Thank you.
reflected in this one?
it is, however, it's a very simple, I don't know, 1, 2, 3, 4, 5 word sentence. And I find it all encompassing, I guess. I find those 5 words all encompassing to me personally. Today, Alyssa, try to make someone's life better.
I think it could be the number one, go up at the top, even though it would make it should rewrite the whole board.
But that's not bad to end with it.
I like ending with
Like,
it.
that's what you remember at the end.
Yeah.
The last thing.
It's kind of the last question I always ask myself.
So
But
my modus
disagreements.
operandi is to get to the end with all the input that's necessary. So I'm gonna go right then.
Oh, I had another recommendation that's not on the board that I didn't send
And
you
we're gonna
yet.
hold that.
Okay.
Making someone's life better today. Do we want to add it?
I don't know if I'd use today, every day. You know, I don't mind adding that, but I don't know if I'd use the word today. That's one day, today.
You're talking about every day.
Well, I don't know if it's necessary. We want to make someone's life better.
We won't police you, Alan.
What about make someone's life better? After 650,000 days, then maybe we'll get around to.
Yeah, that's funny.
I like it today because it's aspirational, it's a reminder. And it could be something really simple.
That's simple. I don't mind it. I just,
And we'll do this in
Don't worry
orderly
about
manner,
tomorrow, just
orderly
today.
manner. Are you okay with it? Make someone's life better.
I don't know if I want to do that. Yes, yes, absolutely. I'm okay with it.
Well, no, you don't have to be. And
Yes.
You don't have to be.
I am
Yeah.
part of the committee today, right now, so I have no greater say in anything than anyone else. So please don't feel.
I
you have
am, but
to-
I wonder if there's a way we can phrase it so that it's the same sort of scope as these, because I feel like it's a different scope than all of these, and maybe that's the point.
That's the point, is that it is just a broad scope, and it isn't all encompassing. It's just a mantra.
And is it supposed to be something that when we're making policy, it's embedded in the policy, or it's an individual guiding principle?
To me, it's an individual guiding principle. When we have gone through all of these and we have addressed all of these, I always ask the question at the end, does this make someone's life better?
Okay,
That's
now.
Yeah.
Um,
I like it.
Daisy, I know you well enough, and I know how well you write.
no.
As we're going around the table, I would like you to think about, can we add that in any other place? Or is it better standing alone right here?
Okay.
Okay,
My recommendation would be not to have it be a principle, but to have it be a mantra and just write it at the end. Something at the end that's not a bullet point, like it says guiding principles, ... And however you want to word it, make life better, or something like that.
Like that.
So it's sort of like you said, it's a mantra. It's not necessarily a principle. It's a closing mantra that goes at the end. That would be my second recommendation. And it's like we're naturally fitting it
I
in.
mean, something like this, let's make sure that we make somebody's life better.
Yeah, or like, let's make life better or something.
Can I comment?
It's not your turn yet. I'm not done, but it's okay. The only thing I want to say while I have the mic is that I wouldn't change this too much, but something I've been thinking a lot about is reducing harm versus repairing it too. Sometimes all we can do is make suffering a little bit less, like palliative care. I hate to put it that way. Like so I don't want to change this at all because I think it's good. I'm just saying that when I think about what you're saying about making someone's life better, sometimes making someone's life better is just easing their pain for one day. And that might sound sad, but when you can't save someone's life, you can at least make it better while they still have it. And then the other thing is, And yeah, that's all I would say. And improving quality of life is another thing that came to mind just now, but. I'm done. Mike is hand it off.
I think it's awesome, because I think that everybody should try to make someone's life better every day. If you just walk out there and say hi to somebody, it's a ripple effect, and I think it's created, we've heard about community. We have suffering communities right now, and I just think if everybody had that mantra, maybe it would be a little bit better. I love it.
Thank you.
Make some life better, or every day, or today, or better, I don't care.
So you don't have any problem?
Stay Montana, no, I don't have a problem.
All right, thank you. Leslie?
I think we all have attachments, personal attachments to each one, different ones of these because of how we think about our role or what we care about. But I'm thinking about what you're saying more as a question. Did we make someone's life better today, in our work? And to me, that resonates more than, because today, we're just gathering in information, and maybe today we didn't. When we think about that question, but it's not a declarative sentence that we have to, because we're not gonna I know it's a mantra, I know it's an aspiration, but for our committee, I guess for me, the question is, did we do that? And that's more resonant for me.
And to me, the word someone's is the most important word to me, because I am oftentimes deeply frustrated if we're not able, it feels like sometimes we're unable to do what we really want to do. And sometimes we're forced to make decisions that, are not in the best interest, but need to be made because we're in the role and the position to make the hard decisions. And sometimes, again, I like Brian's thought of it's not necessarily a guiding principle, it's a mantra. And I just like to remind myself every day, did you do something today that made someone's life better? You want to make everyone's
It
life
might be my
better.
life. You might make my life better, right? So it's the population of making God's
I
better.
think about it more in terms of the work we do as a committee.
But I'm thinking
and
about,
what we do in the legislature as opposed to personal.
no, but I'm thinking within
The other thing I have now written on my aspirational is build human connections.
yeah, that's what I'm thinking. That's why I'm going there. It's the same.
Okay, look,
Yeah,
just from hearing
Yeah.
what you said, how does this sound? Does it change this? Do our decisions make someone's life better?
Go on, I wouldn't do that.
Does,
I wouldn't ask a question.
what?
I wouldn't put it as a question.
That's a question.
No.
No, not as a question.
No,
I'm with Brian. I think it's a standalone that we should put, write or print. and
By
put up
itself.
somewhere. Yeah,
okay.
As Alyssa wrote it
yeah,
with Brian's.
yeah.
Well, how does it
We
evolve?
should hear from both of them. because-
Yeah, I want to hear from, that's what I'm trying.
Yeah, I know. I'm
Have a
trying.
conversation at the same time. I mean,
Yeah, but Debbie didn't even get to speak.
well, she will, of course.
Yeah, so I support exactly the way Alyssa wrote it, simple, direct, that's what mantras are. They're easy to remember, you can use it in whatever way fits you. And as a bullet, not as a bullet point, but as a.
Thank you.
I'll go with the flow.
I didn't hear you, I'm sorry.
Go with the flow.
I didn't want to add that to our guiding principle.
Go with the flow.
We're going to go with the flow and make somebody's life better.
Although sometimes you have to stand up to the flow to make.
All right, we're getting near the end of this. We're getting near the end of this. Did you have any ideas how it should be written, if it should be written differently or added in? Or do you want to leave it, like you said, by itself?
I think it's by itself. Otherwise, it would be integrated with the aiming to.
Okay. All right, now by itself, it means make someone's life better.
I always say to myself, make someone's life better today. But if everyone wants to drop off the today, then
We can say today and every day.
yeah.
Or today
Makes-
is tomorrow too.
It's like, it could say like, make someone's life better today and every day, or
Today's good.
I think today is fine.
Today's enough.
I can think of, can I just say this just for the sake of argument? I can think of how it's problematic, but I know it's not what
I
we mean.
know.
Because making someone's life better today could be giving the governor another raise. We made his life better today. But that's not our intent. Our intent is, yes, that is not our intent. So I'm fine with putting, make someone's life better today,
So,
because we know what it means. It's
So-
for us.
Go Bob.
so now I'm gonna interject something. I think your idea is great. I think the people around this table have made their choice. And the individual from Boston University is going to decide, without adding anything, as the member from Dartmouth, I think you went to school.
Oh, me? Yeah, you said Boston. I was like, who's that?
Yeah, so who the hell you think it is? It's only me. Okay, so I want to thank you for all the time you took.
It's a recommendation.
Oh, I thought we were, okay.
I'm sorry. Might we contemplate adding something about being a welcome partner to other stakeholders across the system? I'm noticing that, one, I'm saying it a lot. Other members are saying it a lot. We just got a letter from Blue Cross. They mentioned a lot about coming to the table and working together. And we have mentioned providers.
How about number 2?
Where do we see providers?
Doing no harm. No, I mean, perhaps number 1, being grounded foremost in supporting a positive experience within the system of care. But do we call out clearly enough that we are open and willing partners in collaboration to improve the system of care? I don't feel like we're specific enough, and I'm open to,
We could never get specific enough. Would always leave out
for
something.
you maybe. Just kidding.
I'm trying to see how what you say fits in here. I see Mari's hand out of the corner of my eye too.
I like that and would want to keep it really short. So being grounded foremost in supporting a positive experience within the Vermont system of care, including, can't think of the adjective, but something, partnership with all stakeholders across the state.
Collaborating.
I don't know why it's not covered.
A strong partnership, a vibrant partnership, an active partnership with all stakeholders.
Or that really keeps it person-centered, having it just as is, being grounded foremost in
Yeah.
a positive experience. But if we did if we modified aiming to improve population health, support health equity and individual wellness through collaborative partnerships
That's good, right?
with,
Just like do collaborative partnership or do
through
collaboration.
collaborative partnerships with, what do you say? I don't want to use the word stakeholders
Yeah,
again.
That's why I think just do
Not
collaborative
too long,
partnerships covers it.
But through collaborative partnerships.
Yeah, you don't have to say with who. It could be with the devil, as long as it helps people. I'm just kidding. I'm kidding. I'm totally kidding. That was sarcasm, okay?
What is that with guy, huh? Devil.
Collaborative partnerships across the
Yeah,
system.
well, that's why I'm taking liberty of.
Okay, stop, please. Daisy,
Aiming to improve population health, support health equity and individual wellness through collaborative partnerships across the system.
Yeah, how do we get at people though? System is like a collaborative partnerships.
We're not talking about people, we're talking about what our aim is, which is to do those things through collaborative partnerships across the system.
Okay.
All the rest of these are about people. But we're talking about the people who build the system for the people. And we can't ignore that they have a hand in creating that environment. And we need to call that out.
okay, thank you.
I think that's important. But I'm wondering if it goes in the next to last bullet, that there's an opportunity there as well, because it's also talking about the system. And just adding with collaborative partnerships. There, but it doesn't matter, as long as we have the words. I'm happy with it anywhere, to tell you the truth.
Right, let's
Okay, here and here.
addressing barriers to accessibility, affordability, sustainability across the health system by supporting collaborative partnerships.
Or with strong collaborative partnerships, addressing barriers to blah, blah, blah.
I think we can take that out, first of all, because it's too, take out and efficiency because it's too long.
Addressing barriers to accessibility, affordable, working with health, working with our healthcare partners. I mean, Green Mountain Power, the hospitals, all the people that have been in, I mean, they're all our partners.
Yeah, we know who the partners.
So are the patients though,
That's right.
and the impacted people. That's why I
But we
think
need to
probably
speak to
earlier.
the health system and the people who are there. I think we need to speak directly that we are a willing partner with those people. That's my point.
Well, it would be, if we did it on the next to last bullet, it would be like addressing barriers to accessibility, affordability, and sustainability, working with our partners across the health care, across the health system. Just take out inefficiency and says, working with our partners across the health system.
Okay, that sounds fine. The working with, collaborating with, I think
That's good.
sounds better.
I'm good with that.
Yeah, I think that's more in keeping with.
Does anybody have any problem with that?
Did someone write down that language?
Did you really like that? Did you write it
I
down?
started
It's
to, and
just
then I,
this.
Daisy, maybe
It's
you
just
could,
collaborating with.
okay, so we're gonna,
we have to get.
we'll get it.
Collaborating with our partners.
And I
Um,
believe, Leslie, were you the one
Daisy,
that handwrote
would you
that?
please write that?
My handwriting was horrible. I think Lori
Far.
did it.
you did write prescriptions. I don't trust
And
you.
we'll give it.
Yeah, we need someone better handwriting.
I think it was Claire, maybe next time Claire's in the room, we could ask her if she.
I can collaborate in the
Just
cafeteria.
making
Handwriting. You can
I
copy
can
it.
mimic it, yeah.
Okay, Tucker, could I add something to that?
Yeah, sure.
In the line about being mindful of social determinants of health, I'm just thinking about in our evaluation of legislation, that we really take that into account when we think about legislation, the impact on social determinants of
Well,
health.
yep, and that's why it's there.
I'm not asking the changes, but I want to add to that, just something to think about. When you talked about evaluating the impact on the social determinants of health, that the Office of Racial Equity created a tool, an equity impact assessment tool that no one is using
Right.
to measure. So it might be just something to consider, like that when we're in the end stages of passing a bill out of committee, either to quickly use that tool together or have a subcommittee use it and report back. And that we might look at, is there a way to integrate that with something on the social? For example, we're like about to vote a bill out of committee the day before, a subcommittee looks at it, uses that tool and a social determinants tool, and the next day says, or maybe not the last day, but like somewhere in the process, just something to think about in terms of process that would support that principle. I just want to. pick that up.
Yeah, that's one tool. I think there are many.
Yeah.
So, I was thinking about the bills that are up there. It can get very narrow focus because social determinants of health are complicated. But anyway, that
Okay,
was just I was hoping that we would I don't think we used that.
Good.
It's a great bullet, but I don't think we applied it. And I'm just wondering how we use that when we consider legislation. So it could be being mindful of social determinants in considering all our legislation, that's all. When considering our legislation, something like that.
Or even in the practices, like having lunch on time.
we are going, okay, now, everybody have their say? Okay, she's gonna print it.
I keep pointing at her.
Print that for us, we'll get it set, and we'll have that changed.
Well, before we change it up there, I think it would be great for us to see the edits.
Look at it.
Yeah, and then,
Do you want me to share this?
I don't know if we're going to do that right now. Yeah. that would
We'll
be-
go to lunch.
I have a meeting.
I'm just gonna show you where it fits.
Can we remember we're still live?
Oh, I did.
I knew we were.
Are we all set?
Hold on.